Thank you very much for this kind introduction here. Well, we heard a lot about what happens with the myocardium if there is something going wrong with the coronary arteries, and I will talk a little bit how the coronary arteries directly can be visualized by modern technologies like cardiac CT. I will just briefly give an introduction about the technical basics of coronary CT angiography. I will give you an overview about the current status, about what we can do in the clinical work. Of course, there are still some limitations, but there are even ways to overcome these limitations. And finally, I will try to give you an outview about the upcoming future trends of the use of these exciting techniques. We could observe in the last couple of 10 years a fascinating improvement in the technical possibilities of cardiac CT. And based on this improvement, the use of cardiac CT increased and is increasingly used for the management of coronary artery disease patients. Especially cardiac CT becomes a major trigger for innovation in computer tomography technology. The main issue or the main challenging problem at cardiac CT is the motion of the heart during the cardiac cycle, and we have some relation between the heart rate and the movement of the coronary arteries. So we have just a very, very short period of time here in the second part of the diastole, about 20% of the whole endurance of the RR interval of one heartbeat. This is the only phase where we can image the coronary arteries without any motion artifacts. The problem is if the heart rate of the patient increases, this is the example for 60 beats per minute, which is really low. If the heart rate increases of the patient, even this period of time where we can image the coronary arteries becomes shorter, and so it becomes more critical to image the coronary arteries without any movement. Good news, or the good thing, is that we could observe, as mentioned, an exciting improvement of the temporal resolution during the last couple of years. We started with cardiac imaging by using 4-slice scanners. The temporal resolution at that time was 400 milliseconds, which was not enough. And we are now working with scanners with a temporal resolution at the range of 80 milliseconds, and there are new scanners coming out providing a temporal resolution even below 80 milliseconds. So an exciting improvement in temporal resolution in a very short period of time of less than 10 years. At the same time, even the spatial resolution could be improved, which is very important, especially for the coronary arteries, since the coronary arteries are very, very thin vessels. In the 4-slice era, we had a spatial resolution of just 1 millimeter. We are now dealing in routine means with a spatial resolution at the area of 0.5 to 0.6, which is a big improvement for the coronary arteries. And finally, even the acquisition time could be improved. In the 4-slice era, again, it took about up to 40 seconds to image the entire heart. It's more or less impossible to hold your breath for 40 seconds if you are in the scanner and the contrast is injected. Right now, we are currently and routinely working with an acquisition time below 10 seconds, so even breath hold is not an issue anymore, and we don't see any breathing artifacts anymore. Just again to mention the relation between the heart rate and the time for imaging. So as the higher the heart rate, the shorter the period of time where we can image the coronaries, and I will mention this problem again as one of the major limitations of the technology. Right now, cardiac CT becomes a little bit more complex. We can choose from different scanning modalities and scan modes. The selection of one out of these modes mainly depends on the heart rate of the patient, so we should individualize our scanning protocol. But it makes a very big difference to the patient for which mode we vote, since the dose range for the radiation exposure is between 1 millisievert up to 15 millisievert. So it makes a big difference for the patient if you choose a step-and-shoot technique or if you choose another technique. I will not focus too much on the technical details. I will just show you the big range of the radiation exposure and how important it is to choose for the appropriate scan mode. It has been published even with a very new technique, the step-and-shoot technique, that really high diagnostic accuracy can be obtained. However, it's just useful in the ideal patient with a heart rate below 60 beats per minute. And usually the patients coming to a cardiac CT never have such a beautiful heart rate. Just again, to mention, it makes a big difference for what we are using here. Between 1 millisievert up to 8 millisievert is a big difference to the patient. So we should be involved all the time in choosing the appropriate scan mode and in individualization of the selection of parameters, depending on the heart rate, depending on the body mass index, and so on. We are dealing with 1 millisievert scans, which is very, very low radiation exposure, up to 8 millisieverts. However, there are a lot of tools for radiation dose reduction. This is the good news. So we can use cardiac CT at a really low dose if we are able to individualize and if we are able to put all the radiation dose reduction techniques into our scan protocols. And it has been shown that the possibility of a dose saving is up to 86%. So if we are doing a good job in individualization of our scan protocol, radiation dose is not the big issue for cardiac CT anymore. Therefore, and even based on all the other technical improvements over the last couple of years, coronary CT becomes the method of choice in a couple of very important indications, and I will show you right now the most important clinical indications for using cardiac CT in patients with suspicion of coronary artery disease. The most important indication and the most appropriate and the mostly and best published and included in all the recommendations indication is the rule out. So the rule out of a coronary artery disease in patient with low to intermediate risk for the presence of a coronary artery disease and a normal or uninterpretable ECG, or a patient unable to exercise. So it's a perfect indication since cardiac CT is able to rule out the coronary artery disease with a really high negative predictive value. And I will show you that there are some patients in whom this indication is really important. Again, it's recommended to use it only in patients with a low to intermediate predeath probability. And this kind of patients really do exist. There are a couple of patients in the clinical routine, patients like this. So a male patient around 50 years old with a newly developed chest pain, hypertension for 5 years as the single risk factor. So it's a typical low to intermediate risk situation. No additional risk factors, no ECG changes, no changes in the cardiac enzymes. And in such patient, it's very helpful to have a non-invasive, safe test to be able to rule out or even to detect the coronary artery disease. And it's obvious that if you can produce such beautiful images showing the coronary arteries to the very distal end, here the LAD, here the RCA, and the circ, it's obvious that if we can produce such beautiful images that we can rule out the coronary artery disease. It's obvious that this patient doesn't have a coronary artery disease. Can we trust these findings? The answer is a clear yes. There's a really, really good evidence in the literature. Hundreds of papers have been published during the last couple of years, and all of them are ending with a really, really high negative predictive value between 99 and 100%. And honestly speaking, there are not that many tests in medicine available providing such a high negative predictive value. So with other words, it means if the coronary CT is negative, then you can trust these findings. This patient will not have coronary artery disease with a negative predictive value of 99% or even higher. And again, there are not many tests with such a high negative predictive value in entire medicine. So the rule out is a very, very important and very, very helpful indication and the most appropriate and the best thing. It's even helpful in the emergency situation. It has been shown by a couple of papers that we can use this technique even in the emergency situation to rule out an acute coronary syndrome. It has been shown by the so-called ROMICAT trial that in more than 50% of the patients coming into the chest pain unit with the suspicion of an acute myocardial infarction could be ruled out, could be discharged from the chest pain unit at a very, very early stage after doing the coronary CT. So in 50%, we could end all our diagnostic roll-up just after our CT scan. And I mentioned before, it took just a couple of seconds. So it could be very, very helpful even in emergency situations. The next question maybe is CT just helpful to rule out? Can we just image normal coronaries? No, the answer is no. Of course, we can even image diseased vessels. Another example, very, very similar patient to the previous one, male patient, around 50, newly developed chest pain without any enzyme elevations, normal ECG. Again, hypertension, so it's a typical Viennese population. All the people here have hypertension and elevated LDL levels. That's due to the Viennese cuisine. So it's one more risk factor. So this patient is more in the intermediate risk group. And even in this case, it was very helpful to do the CT. And of course, we can even demonstrate the diseases here. And it's obvious that there is a high-grade stenosis of the LID. So this patient has a coronary artery disease. Can we trust these findings? Yes, of course, we can. In these papers, as presented before, even the positive predictive value was pretty high. Not as high as the negative predictive value, but still very, very good. So the diagnostic accuracy is really high, even for the detection of diseased arteries. And the good news is, in comparison to older papers, that the number of non-accessible segments becomes lower and lower by any new innovation of the scanner techniques. So we can use it for rule out, we can use it for the diagnosis with a really high negative and positive predictive value. We can use CT even for treatment planning. So even in some patients, even after coronary cath, it can be helpful to have additional image information. So cardiac CT can help to plan complex treatment procedures. For example, chronic total occlusion, so that means chronically occluded coronary arteries. It's a complex treatment, it's a complex intervention in the cath lab, and it could be helpful to get additional information, and I will show you why. The revascularization of this chronic total occlusion is a widely accepted procedure. It accounts currently for about 10% of all procedures. However, these chronic total occlusions are still a main reason for a bypass graft surgery. And the success rate of the revascularization of a chronic total occlusion is much lower compared to non-occluded lesions. So we have a technical success rate at coronary angiography for 90% for non-occluded lesions, but only for 63% for true chronic total occlusions. However, the revascularization of the chronic total occlusions are important for the patient's outcome. It has been shown that patients have a significantly improved 10-year survival rate after successful revascularization of a CTO compared to patients in whom the CTO revascularization was not successful. We know different reasons and factors why a CTO PCI can failure. It could be the inability to across the lesion into the true lumen distally to the occlusion, or there is a higher risk for some complications during interventions like dissection or perforation. Factors for failures for CTO PCI are the greater lesion length, are the age of the occlusion, are excessive vessel and lesion tortuosity, and calcification. And the good news is that CT can answer most of these questions. CT can show the length of the lesion very easily. CT can show if there are calcifications or not very easily. And CT can show if there is a very straightforward occlusion or if there is a big tortuosity. And I will show you a clinical case. It was a around 50-year-old male patient coming with an occluded LID. So this is the coronary cath. You see here the occlusion, but it was not possible to assess at coronary angio the length of this occlusion, so it was not clear if there is any distal outflow vessel and if the revascularization could be helpful. So after the coronary cath, patient was sent to CT, and we could answer very easily to the question, and we could demonstrate that the occlusion was a very, very short one, a very, very straight one without any calcification. So we were convinced after looking at the CT that the revascularization might be successful, and this is the control angio after successful stent implantation of the occluded LID, and you can see a very, very distal, very, very nice distal outflow here. So it can be helpful even in addition to the coronary angio. Another example, patient with a chronic total occlusion of the RCA. It was not clear at angio if the CTO PCI could be successful or not. And CT shows a very long, non-calcified, non-tortuous lesion, but very important, we have big collateral vessels at the beginning and the distal part of the lesion, and this is very critical, since if you try to pass this occlusion, you will end up all the time just in the collaterals, and exactly this happens during coronary angio, so it was not successful. The CTI PCO could not be done. The reverse colorization was not possible. Finally, a very good indication for cardiac CT is the treatment follow-up. So after bypass graft surgery, CT can be used to demonstrate the anatomy and the patency of the bypass graft. So this is a so-called Lima graft coming from using the internal mammalian artery. And here, nice demonstration of the anastomosis to the LID. Same example. Here's the course of the bypass. Here's the anastomosis. Another example of a graft going to the first diagonal branch. Here you can assess the anastomosis and the course of the bypass graft. So bypass graft patency is a very good indication. Even this has been shown by a couple of papers showing, again, a very, very high diagnostic accuracy, a very high negative predictive value for bypass graft lesion detection. Another example of a very complex bypass anatomy, just to give you an impression how the patient after bypass surgery looks like and how helpful CT can be in demonstrating the patency and the anatomical situation. Stents are critical. However, they are used in increased numbers in cardiology, so we are confronted with patients after stent implantation. Sometimes it works pretty fine and we can assess the stent very nicely. Sometimes we can see even the instant restenosis, and sometimes we can assess the occlusion. But it doesn't work all the time that fine. There are a couple of papers describing this. I really like this paper published by a colleague from Marco, describing that up to a third of all the stents were not accessible at coronary CT. So the stent patency is not a good indication, since we don't know in advance if we will be able to assess the stent. In this case, it was possible. But in this case, we can just report, yes, there is a stent at the RCA, but we can't say nothing about the stent patency. So the question for stent patency is not a good indication. Well, you have seen a lot of nice images, and I mentioned a lot of papers and high numbers of negative predictive values and sensitivities, and everything looks pretty fine. Well, of course, even cardiac CT is not perfect. There are some limitations. The most important one is the grading of stenosis, maybe the problems with the heart rate, obesity, and severe calcification. The grading of stenosis is a problem. Again, it's very easy and very, very good to use the CT if the case is normal. If the coronary arteries are normal, then we are sure, we can believe that the negative predictive value is high. We can rule out the coronary artery disease without further discussion. But we run into some problems if we have a patient like this with a known three-vessel disease. In the last angio 3 years ago, there was no relevant stenosis. Now he comes back with a chest pain, and it was admitted to CT with the question, intervention needed, yes or no. A very poor indication to coronary CT, and I will show you why. Of course, we can demonstrate the lesions here. We see a short occlusion of the RCA with huge calcifications there, and we see a really long lesion at the LID, and it's very, very hard to describe if this long lesion here is relevant or not. And that's the big limitation of CT right now. If you're looking just for the coronary morphology, it's very hard to describe if a lesion is really hemodynamically relevant. The point is, it's even difficult at coronary angio, but the cardiologist has the advantage if he puts a stent in, per definition the stenosis was relevant, because otherwise he wouldn't put the stent in. So it's a self-fulfilling prophecy. We don't have the ability, so we have to decide is the stenosis relevant or not. And sometimes it turned out at coronary angio that morphologically relevant stenosis are not hemodynamically relevant or vice versa. So this is, of course, one of the biggest limitations to assess the functional relevance of the stenosis. What about the heart rate? I mentioned in the very beginning of my talk the relation between the heart rate and image quality. We know that since the early times of cardiac CT, the higher the heart rate, the lower the image quality will be. So this is a problem. What we do and what is really helpful is we give beta blockers to the patient, and this helps to reduce the heart rate. It's a very, very safe, very, very well-established treatment to reduce the heart rate and to optimize the situation for the coronary CT, and it should be used in really excessive way to optimize the image quality. A very interesting paper published a couple of years ago has shown that a lot of patients receive the beta blockers, but there is a huge number of patients receiving insufficient beta blockade, since some radiologists are really afraid to give drugs to the patient. They prefer just to look images. If we are doing cardiac CT, it's very important that we even act as a doctor and that we give beta blockers up to a really high dose, but this will ensure that we end up with a good image quality. However, there are some situations and even patients where the heart rate can't be lowered. In this situation, patients, we should look for different options. For example, in children or in emergency situation or in patients with atrial fibrillation, it's usually not possible to limit or to reduce the heart rate. But there are even tools or possibilities to go. As an example, patient right after coronary artery bypass graft surgery, still on the intensive care unit, poor ventricular function, poor general condition, and the patient was referred to CT to assess the bypass graft patency. So it's very easy to assess the bypass graft, since the bypass grafts are not that nearby to the myocardium, so pulsation artifacts are not that common for bypass grafts. And we could image this patient with a really high heart rate in a poor general condition. So it was would not be a good idea if the radiologists start to giving beta blockers to patients coming from the intensive care unit. So we scanned the patient without any beta blockers with a really modern scan technique, and it was possible to assess and to demonstrate the bypass graft patency in this case. Another example of a newborn below 3 kilograms with a complex congenital heart disease, and the question if there are some possibilities for surgical treatment, yes or no. And the patient comes in with a heart rate of 140, which is normal for kids at that age. And of course, it's not possible to reduce the heart rate up to our target heart rate of below 70. So we imaged the patient even at the high heart rate. And as you could see, really nice images could be obtained showing this ventricular septal defect, showing the overriding aorta here, and showing this aortopulmonary collateral arteries in this patient with a pulmonary atresia. And the really nice thing was that the radiation dose was at the area of just a couple of chest X-rays, or pretty low. We can use this modern so-called high-pitch technique in patients with high heart rates, and we can obtain good image quality even in a couple of patients there. Is obesity a problem? Not really. So there are protocols, even XXL protocols, which can be really helpful and can produce even very nice images, even in very obese patients, even up to a body mass index of up to 60. So really obese. They can image if the table of the scanner is able to hold this patient. Calcifications are a problem. It's very difficult to assess the stenosis behind calcifications. And we know that patients with a high rate of calcifications are at high risk for coronary artery disease. So this group of patients are not good candidates for a cardiac CT. We heard that the most appropriate indication is to use this technique in patients with a low to intermediate pretest probability. So if the coronary calcium is pretty high, then the pretest probability is high as well. What are the future trends? What we can expect in the next very few couple of years? What is new? The scanner becomes faster, bigger, and safer. And you can even see here on in the exhibition, really fantastic scanners are shown here. And of course, if the scanner becomes faster, bigger, safer, better, nicer, and whatever, this allows for new applications and indications. What will come up is plaque assessment, which could be a very important thing. It has been shown by a couple of papers already that plaque assessment is possible or becomes possible by using CT. A very big study on more than 1,000 patients, and to show the clear correlation between some morphological features of a plaque and the outcome of the patient. So if the plaque has a really low density at CT, the event rate was significantly higher compared to patients without these findings. And it has been shown that this is a typical morphology of a plaque at high risk for rupture. It's a non-relevant stenosis with regard to the morphological criteria. However, we have a big remodeling of the plaque, so we have a huge plaque mass even outside of the vessel lumen, and we have a very, very low density, and these has been shown to be plaques at high risk for rupture with a high correlation to acute myocardial infarction. So this could be a very, very interesting and important thing to go in the next future if CT shows in the clinical routine to be able to demonstrate even the plaque morphology. Mentioned before by Marco how important even the cardiac function might be. So CT is even able to demonstrate the cardiac function, not at that high temporal resolution as MR, but high enough, I guess. It has been shown a couple of years ago that we can use even the wall motion abnormalities to differentiate between acute infarction and chronic disease. Here just one example. So it's not mandatory to reconstruct some fancy movies. So you can even look for the static images, and if you compare the diastolic with the systolic image, you can see that here is no thickening of the wall in systole, as well as here at the lateral wall. So you can describe a hypokinesia even by looking for the static images at CT, and you should implement this in your routine report. This should be a movie, doesn't work, I'm sorry for that, showing the same thing, that there is a lack of thickening at the anterior wall here, described as hypokinesia. And finally, myocardial perfusion becomes possible, as we already heard, even by CT. Myocardial perfusion is still under clinical tests, but I'm pretty sure that within just a few years, myocardial perfusion by using CT will become a clinical routine. There are a couple of papers demonstrating perfusion and data enhancement, as we have shown by Marco already, could be a very, very important and interesting new tool for using cardiac CT as well. Finally, maybe even the indications will change or might change. Even in high likelihood, we can use this technique. There has been a paper published last year showing that we can use CT even in a high likelihood. And of course, there are patients in whom this could be important. 6 years ago, the so-called COURAGE trial has been published in the New England Journal of Medicine. And this leads to a big discussion in cardiology. Just briefly, they compared optimal medical therapy with, they compared the optimal medical therapy with coronary revascularization in patients suffering from coronary artery disease. And they found out that the revascularization did not reduce the risk of death, myocardial infarction, or other major cardiovascular events. After 3 years, there was no difference between the two groups. So just briefly, these COURAGE trials and all the upcoming trials based on the COURAGE trials showed that not every stent really improves the quality of life, and not every stent improves the outcome of the patient. And this is the position where maybe non-invasive imaging can be helpful. Even in patients where we know that they are suffering from coronary artery disease, there is the decision to make right now, should the patient undergo revascularization, or maybe the patient is better treated just by medical treatment. And here CT can help, as been shown by this very recently published paper in patients with a high likelihood. And they concluded that in patients with a high likelihood of coronary artery disease, the performance of CT in the differentiation of patient without and patient with a need for revascularization was possible at the same level to that of cardiac catheterization. So maybe we can change our indication in much more indications to a AAA rating for coronary CT in the very next years. Let me conclude. We could see a tremendous improvement in technical possibilities of cardiac CT during the very last few years due to a significant increase of spatial resolution, significant increase of temporal resolution, significant decrease of acquisition time and radiation dose. We have a very high negative predictive value in the rule out of coronary artery disease and a very high diagnostic accuracy in the detection of coronary artery disease. So treatment indication, planning, and follow-up can be done at a very high level of accuracy by non-invasive coronary CT angiography. Plaque assessment might become possible by means of CT, and maybe integrated cardiac diagnosis, including morphology, function, and viability, could be made by cardiac CT in the very close future. And I'm pretty sure that the indications will be expanded and will also include patients with a high predisposed probability in the very next future. Thank you very much for your attention.